So, imagine injecting this highly touted, like miracle healing serum straight into a painful mouth ulcer.
Right, expecting it to just fix everything overnight.
Exactly. You fully expect it to repair the tissue, instantly. But instead of healing, your immune system basically enters a state of sheer panic.
It's a total biological lockdown.
Yeah, it walls off the injected liquid and literally turns the surrounding tissue into this hardened mass of scar tissue that just refuses to go away.
Which is definitely not what the brochure promises.
No, not at all. And that is the actual biological reality we are exploring today because, you usually hear about regenerative medicine as this clean, simple fix.
Yeah, they market it like a software update for your body.
Right. You download the patch, the bug is fixed, and your system just runs smoothly. And right now, exosomes are, well, they're the ultimate biological software update.
They really are everywhere.
You see them advertised for literally everything, from getting that glowing skin to miraculously closing up stubborn wounds.
Well, the marketing narrative relies really heavily on this comforting, almost simplistic idea.
How so?
The pitch is basically that we can isolate these perfect cellular healing instructions, these tiny microscopic bubbles called exosomes, and just deliver them directly to damaged tissues.
And just command the body to repair itself.
Exactly. It treats human biology like a highly predictable machine,
Hmm.
which, as we know, it isn't.
No, definitely not. And when you step out of those glossy cosmetic brochures and actually look at the clinical reality of treating severely damaged tissues, that clean software update starts to look, well, incredibly dangerous.
It really does.
So today, we are bringing you on a deep dive into a very specific high-stakes corner of this regenerative frontier. We've got a massive stack of sources today.
Yeah, we're looking at clinical case studies, dental research on periodontal pockets.
Right, and dermatological reviews, plus some really urgent alerts from the CDC. And our mission today is to answer one central, critical question.
Which is, what actually happens when you inject exosomes directly into compromised or ulcerated mucosa?
Yes, because we are going to explore the dark side of this therapy today.
And it's important to say, these tiny extracellular vesicles are absolutely meant to be cellular messengers that accelerate healing.
Sure, in theory.
But when a clinician decides to, bypass the body's natural barriers to deliver these therapies into an environment that's already damaged, they open the door to a severe cascade of risks.
Like localized infections and micro-abscesses.
Exactly. And some truly bizarre foreign body reactions where the body basically goes to war with the treatment itself.
So if you have ever been curious about the cutting edge of regenerative medicine, or if you've been wondering if that exosome treatment your local clinic keeps pushing is maybe too good to be true, stick with us.
Because what happens at the microscopic level at the tip of that needle is just wild.
It really is. Okay, let's unpack this, starting with the fundamental logic. Because I'm looking at these studies, and I see clinicians trying to inject exosomes into already compromised mucosa.
Right, which seems backwards.
Yeah, why do that? If a piece of tissue is actively ulcerated, bleeding, damaged, what is the goal of piercing it again with a needle?
Well, the clinical challenge is really all about localization. Think about the environment of the oral cavity, for instance.
Okay, the mouth.
Yeah, the mouth is arguably one of the most difficult environments in the human body for treating wounds, like oral ulcers or periodontal pockets that form around dental implants.
Because of all the bacteria?
That, but also just the fluid. If a doctor simply applies a topical healing agent to an ulcer, the constant flow of saliva, combined with just the mechanical friction of talking, eating, swallowing, it washes that medicine away in a matter of minutes.
Oh, I see. So the tissue never even gets the chance to absorb the healing molecules.
Exactly.
It's like trying to meticulously paint a wall while someone is actively spraying it with a fire hose.
That is a perfect visual. Honestly, researchers are desperately looking for ways to bypass that constant washout.
So what's their solution?
Well, there is some fascinating research coming out of China detailing the development of microneedle patches.
Okay, microneedle patches.
Right. These patches are loaded with exosomes derived from mesenchymal stem cells. The engineering goal here is for these microscopic needles to physically penetrate the oral mucosa.
Just bypassing the surface saliva entirely?
Precisely. It allows them to deliver the therapeutic inflammation-resolving molecules directly into the underlying tissue bed in a highly controlled manner.
And I read that dental surgeons are attempting similar, like submucosal injections to speed up gum healing after complex implant surgeries too?
Yeah, they are. They want to get the healing signals deep into the tissue where they'll stay put.
Okay, I get the logic of bypassing the saliva, but I'm really struggling with the physical reality of the method itself.
The needle part.
Yeah. Taking a needle or a patch of microneedles to an already severely ulcerated piece of gum tissue just seems incredibly counterintuitive to me.
It is a major issue.
Like, it feels like we are airdropping medics into a war zone, but by using needles to penetrate an already failing barrier, aren't we just punching fresh holes in a leaking dam?
You're not wrong.
We're basically creating a fresh tunnel for surface bacteria to get a free ride deep into the vulnerable tissue, right?
You've hit on it. The physical paradox of this treatment is one of its absolute biggest hurdles. The very act of a submucosal injection introduces acute mechanical trauma.
Right, because you're stabbing an open wound.
Literally.
Hmm.
When clinicians inject exosomes directly into the wound bed or the margins of a mucosal ulcer, which, by the way, they often do in post-laser vascular repair to make sure the liquid doesn't migrate, the needle penetration itself causes localized inflammation.
Just from the poke.
Yeah, redness, swelling, just from the trauma of the needle.
Because no matter how fine the needle is, it's still damage.
Exactly. Now, in healthy, intact tissue, a needle poke is a minor event. The immune system manages it effortlessly. But in a compromised mucosa, the barrier function is already completely shattered. The local immune system is stretched to its absolute limit, just fighting off the ambient bacteria in the mouth.
So it's overwhelmed already.
Yes. So that initial mechanical trauma from the needle can easily become the crucial first step toward a localized infection.
Oh, wow.
The needle physically forces surface pathogens, which are obviously abundant in an ulcerated environment, deeper into the sterile tissue bed. It basically creates a microscopic highway for infection.
Okay, so the delivery method itself carries a huge physical danger, but I was looking through our sources regarding the actual liquid payload being injected.
Ah, the exosomes themselves.
Right, and there is a lot of concern about contamination, like how dirty are these exosome preparations in reality?
Well, isolating a purely sterile, 100% clean exosome preparation is notoriously difficult.
Really? I would think in a lab it'd be easy.
You'd think so. But during the manufacturing process, exosomes are frequently prone to co-isolating non-exosome particles.
What kind of particles?
We are not just talking about harmless stray proteins from the lab here. We are talking about microbial contaminants that hitch a ride during the extraction and purification phases.
Oh, yuck.
Yeah, the biological payload can often carry unintended, highly dangerous passengers.
That's terrifying. Actually, one of the papers highlighted something specific about a bacteria that just blew my mind.
The P. gingivalis study.
Yes. They were looking at preparations involving Porphyromonas gingivalis, which I know is a major player in severe gum disease. But the numbers they found were just staggering. Can you break down what they discovered in those specific vesicle preparations?
Yeah, it's grim. The researchers analyzed these vesicles and found that the preparations could contain up to 1.2 times 10 to the 13th LPS units.
Wait, 10 to the 13th?
Yes, for every 10 to the 10th extracellular vesicles.
That is a massive number. But what is an LPS unit exactly?
Right, let me put that staggering number into perspective. LPS stands for lipopolysaccharide. It is a structural component found on the outer membrane of certain bacteria, and it acts as a very potent endotoxin.
Meaning it's toxic.
Highly toxic to human tissues. So finding that massive concentration of LPS contamination hidden inside a vial of supposed healing exosomes is a catastrophic red flag.
Wait, let me make sure I'm following the clinical reality of this for a second.
Sure.
If a patient has a deep periodontal ulcer and they go to a clinic hoping for a regenerative miracle, they could be injected with a batch of exosomes carrying these massive loads of endotoxins.
Unfortunately, yes.
So we aren't healing them. We are essentially taking a highly concentrated bacterial bomb and detonating it directly inside an open wound.
That is exactly what happens.
Yeah.
And if we connect this to the bigger picture, the clinical consequences are severe.
I can imagine.
When you inject a massive load of endotoxins directly into compromised tissue, it triggers a biological cascade known as potent TLR4-mediated inflammation.
TLR4, okay, what is that?
Think of TLR4 as a biochemical smoke detector built into your immune cells. Its entire job is to detect lipopolysaccharides.
Oh, so it's looking for those exact endotoxins?
Exactly. And when it senses that overwhelming dose of LPS from the contaminated exosomes, it doesn't just sound an alarm. It triggers a full-blown immune panic.
A panic.
The endotoxin contamination fuels a catastrophic inflammatory response. The tissue rapidly forms a localized infection, or, It walls off the area to create a micro-abscess right there in the gum line.
The sources show this isn't just a theoretical lab scenario either.
No, it's very real.
There was an incredibly disturbing alert issued by the CDC regarding clinics in Nebraska. What actually happened to the patients who received these contaminated treatments there?
The Nebraska cluster is a really grim, real-world example of this exact failure. Patients went to various clinics seeking unproven, off-label exosome treatments for issues like joint pain and tissue regeneration.
Just standard wellness clinic stuff.
Right. But because the manufacturing processes for these products were not tightly controlled and the vials lacked rigorous good manufacturing practice certifications,
They were dirt.
the products were heavily contaminated with bacteria. These patients didn't experience miraculous healing. They experienced severe, life-threatening bacterial infections.
Good Lord.
Many ended up in the emergency room with deep tissue infections and sepsis. They required aggressive intravenous antibiotics and even surgical intervention.
So the cure literally put them in the hospital because of poor quality control.
Precisely.
But, okay, let me push back on this a bit.
Go for it.
Let's say we completely solve the manufacturing problem. We have a pristine, high-tech lab. They produce a completely sterile, 100% clean batch of exosomes.
Okay, perfect scenario.
Right. There are no bacteria, no endotoxins, no viral hitchhikers, just pure, unadulterated exosomes.
I'm struggling to understand why the body's immune system would still attack something that is essentially just a biological healing signal. Can you still get an abscess from a perfectly sterile injection?
Yes. The concept of friendly fire is one of the most fascinating hurdles in regenerative medicine right now.
Friendly fire. Yeah. Even if the vial is perfectly sterile, we have to evaluate the cellular state of the donor cell that produced the exosome in the first place.
Why does the donor cell matter if the exosome is clean?
Because exosomes are essentially miniature clones of their parent cell's internal environment. They carry the molecular baggage of whatever produced them.
Oh, wow.
So if these exosomes are harvested from stressed or dying cells, for example, macrophages that have been activated by chronic inflammation, they come loaded with molecules called DAMPs.
Right, DAMPs. I saw that in the sources. They define that as damage-associated molecular patterns. What are those actually doing inside the exosome?
A key DAMP mentioned frequently in the literature is HMGB1. You can think of DAMPs as bright red biological distress beacons.
Distress beacons.
Yeah, they're the signals a cell releases when it is dying or under severe attack.
Okay, so the exosomes are basically screaming for help.
Exactly. If a clinic takes perfectly sterile exosomes that are inadvertently loaded with these distress beacons and injects them into a patient's compromised oral mucosa.
The patient's immune system freaks out.
Yes. It doesn't see a healing messenger. It sees a massive localized crisis. The DAMPs bind to specific receptors in the tissue, triggering a process called rage-mediated NLRP3 inflammasome activation.
Okay, let's unpack that mechanism because the result of that inflammasome activation is a process called pyroptosis. How exactly does pyroptosis affect the ulcer we are trying to heal?
Well, the term pyroptosis translates literally to fiery cell death.
Fiery cell death. That does not sound regenerative.
No, it is not. The NLRP3 inflammasome acts as the cell's internal panic button. When the cell detects the overwhelming distress signals from the injected exosomes, it trips this alarm.
And then what?
The cell rapidly fills with inflammatory chemicals, swells up, and intentionally ruptures its own membrane.
It just pops.
It explodes, spilling highly inflammatory collateral damage all over the neighboring cells. So instead of the exosomes orchestrating tissue repair, they instruct the surrounding tissue to undergo fiery self-destruction.
Which massively widens and deepens the original ulcer.
Exactly. It makes it much worse.
Here's where it gets really interesting to me. It's essentially like sending an email with a corrupted file attached to it.
That's a great way to think about it.
The computer, or the cell in the mucosa, receives the message perfectly. The biological delivery is entirely successful, but the instructions inside the attachment are so toxic that they cause the operating system to completely crash and burn.
The delivery is flawless, but the payload is a self-destruct sequence. And the human body's reaction to this localized biological confusion can be profound.
And it doesn't just happen right away, does it?
No, it doesn't always happen immediately. There is a deeply cautionary clinical case study detailed in the dermatological sources involving a 50-year-old woman.
The cheek injection case.
Yes, she visited a private aesthetics clinic and received an off-label exosome injection directly into her cheeks. Her goal was purely cosmetic. She was seeking wrinkle improvement and skin rejuvenation.
Just a standard, albeit expensive, anti-aging procedure. Given what we know about pyroptosis and immune panic, what was her reaction to the injections?
The fascinating aspect of her case was the delayed onset. 7 weeks passed after the initial injections.
Almost 2 months.
Right. Then she began developing multiple hardened, flesh-colored papules and nodules all over the exact sites where the needle had entered her cheeks.
Oh my God.
Her immune system had been silently brewing a response for nearly 2 months. When dermatologists finally performed a deep punch biopsy to figure out what was happening beneath the surface of her skin, they didn't find any bacteria.
So it wasn't a standard infection like the Nebraska cases.
Exactly, it was sterile.
If it wasn't an infection, what did the pathologist actually find inside those nodules?
The pathology report detailed necrotizing granulomas. In plain medical speak, that means her immune system had built a literal quarantine wall of dead immune cells to trap a foreign invader.
A quarantine wall.
Yes. Inside the center of these quarantine walls, there was a massive swarm of immune cells surrounding what the pathologist described as an amorphous basophilic material.
Amorphous basophilic material. What is that?
It's basically a shapeless, bluish staining blob of biological matter.
Wait, is that just the concentrated exosome liquid? It had just pooled there in her tissue.
Yes, exactly. Her body recognized the concentrated exosome preparation as a massive, alien biological threat. The sheer volume of foreign cellular material overwhelmed her local tissue's ability to break it down or utilize it.
So it just trapped it.
So her immune system resorted to its most ancient defense mechanism, entombment. It created sterile micro-abscesses, or foreign body granulomas, to permanently wall off the exosomes.
And she couldn't just take an antibiotic to fix it.
No. The clinical notes emphasized that these hardened nodules were highly resistant to standard interventions like oral antibiotics or even targeted steroid injections.
That is just wild. The body literally looked at this incredibly expensive, cutting-edge regenerative therapy, decided it was a threat, and entombed it in permanent scar tissue.
It's a huge risk.
But if the body builds a literal wall to quarantine sterile dead material, what happens if the exosomes are carrying, like, active, corrupted genetic instructions from a sick donor? The sources highlight an even more insidious long-term risk when it comes to the sourcing of these biological messengers.
Yes, the sourcing gamble represents the most complex and hidden risk factor in the entire field.
Because you don't really know whose cells you're getting.
Exactly. Exosome therapy relies absolutely on the health, metabolic state, and genetic stability of the original human donor cell. If the person donating the stem cells has underlying undetected health issues, those exact issues are neatly packaged into the exosomes.
That's horrifying.
Research demonstrates that if exosomes are derived from donors with chronic metabolic problems such as diabetes, their therapeutic potential is practically zero.
Really? Zero?
Pretty much. The stem cells are too metabolically exhausted to produce the necessary regenerative signals.
But it goes far beyond just being an ineffective, expensive placebo, right? I was reading this section on pre-malignant lesions, and the implications for cellular mutation are genuinely terrifying.
The dysplastic dangers are very real. The literature clearly outlines that exosomes derived from pre-malignant lesions, such as oral leukoplakia, are fundamentally structurally different from healthy exosomes.
Oral leukoplakia, those are those stubborn white patches in the mouth, right?
Yes, and they have a high potential to become cancerous. Exosomes derived from those types of cells are highly enriched in specific corrupted microRNAs. The most concerning one identified in the research is miR-8485.
Okay, miR-8485. How does that actually alter the behavior of the cells it enters?
It acts as a biological cellular accelerator while simultaneously cutting the brakes.
It sounds bad.
It is. Specifically, miR-8485 actively downregulates a protein called p53. In human biology, p53 is one of our most crucial tumor suppressor proteins. It basically acts as the emergency brake on uncontrolled cell division.
Oh,
So if a clinic inadvertently takes exosomes loaded with this corrupted microRNA and injects them into a compromised oral mucosa, say under the guise of healing a persistent gum ulcer, the exosomes do not heal the tissue.
because they've cut the brakes.
Exactly. By shutting down p53, they actively accelerate cellular proliferation, migration, and tissue invasion.
So what does this all mean for you, the patient? It sounds like if the clinic hasn't rigorously, and I mean flawlessly, screened the donor cells at a genetic level, a treatment meant to heal a simple mouth ulcer could theoretically be planting the seeds for cancer.
It is a theoretical but very real biological possibility based on this mechanism.
How is this even allowed? How is an industry with that level of risk regulated?
Well, the sheer spectrum of these risks, ranging from life-threatening bacterial endotoxins to fiery pyroptosis to the potential fueling of malignant transformation, is the exact reason the FDA currently classifies exosome-based products as investigational biologics.
Oh, okay. So they're not simply over-the-counter serums.
No, absolutely not. They're legally restricted to very specific investigational clinical trials or strictly regulated off-label contexts.
But clinics are still offering them everywhere.
Right. And the core issue is the stark lack of universally enforced, standardized manufacturing practices across the thousands of clinics offering them.
It's all over the map.
The line between a regenerative miracle that seamlessly heals your mucosa and a localized cellular disaster that leaves your face filled with necrotizing granulomas is entirely dependent on the invisible quality control.
Which the patient can't even see.
Exactly. It depends on the absolute sterility and the rigorous genetic donor screening of the specific vial the clinician happens to be holding at that exact moment.
It really is the Wild West of regenerative medicine right now.
It truly is.
If you are going to a local wellness spa or a dental clinic that is offering these miracle cures for a discount, and they cannot hand you the paperwork detailing exactly where the exosomes came from, how the donor was genetically screened, and what their good manufacturing practice certifications are, you are taking a massive biological gamble with your own cellular machinery.
Especially when a patient is dealing with compromised mucosa, tissues that are already inflamed, ulcerated, and highly vulnerable. The margin for error drops to zero.
Because a healthy body might handle it differently.
Exactly. A perfectly healthy, robust immune system might be able to clear a slightly contaminated or biologically confused batch of exosomes. A compromised, failing mucosal barrier simply cannot.
It just caves in?
It'll amplify every single biological error introduced by that needle.
Wow. We have covered some incredibly intense microscopic ground today. Let's synthesize this deep dive so you, the listener, have a clear picture.
Good idea.
We started by looking at the very real promise of exosome therapy. The clinical desire to use these tiny cellular messengers to regenerate compromised tissue is strong, whether that means using microneedle patches to bypass saliva and heal painful oral ulcers, or injecting them deep into periodontal pockets to help bone integrate with dental implants.
Well, the intention is definitely good.
But the biological execution is currently fraught with severe risks that stem from four main pillars. First, the simple physical trauma of taking a needle to an already failing mucosal barrier, which punches fresh holes for surface bacteria to invade.
The mechanical danger.
Right. Second, the severe risk of biological contamination, where massive loads of hitchhiking endotoxins essentially detonate a bacterial bomb inside an open wound.
Which is what happened in Nebraska.
Yep. Third, the phenomenon of sterile immune panic, where distress beacons called DAMPs cause the tissue to undergo fiery self-destruction, leading the body to entomb the expensive treatment in permanent scar tissue.
The granulomas.
Exactly. And finally, the terrifying long-term risk of corrupted donor sourcing, where exosomes from dysplastic cells could actively promote malignant tumor growth by cutting the brakes on cell division.
Tying all of these pillars together is the reality that injecting complex, living biological material into an environment that is already losing its battle with inflammation requires a level of precision and purity that, frankly, many commercial clinics currently cannot guarantee.
So why does all of this complex cellular biology matter to you? Because the marketing for regenerative medicine is only going to get louder and more persuasive.
It's everywhere now.
It really is. If you or a family member or friend is ever sitting in a chair and being offered a cutting-edge exosome therapy, you now have the critical toolkit to protect yourself. You know the exact mechanisms at play.
Don't just trust the flusher they hand you.
Exactly. Do not just accept the glossy marketing brochure. You need to ask for the science. Demand to see the sterility testing. Ask about the precise donor source and their metabolic screening. And you absolutely must ask about FDA compliance and quality assurance.
Questioning the fundamental assumptions behind a miracle cure is your absolute best defense in a rapidly evolving, highly commercialized medical landscape.
Because they're trying to sell you something.
Right. Understanding the mechanism of action is the only way to separate the science from the sales pitch.
Which leaves us with one final provocative thought to mull over. We have spent this entire deep dive unpacking the unpredictable, sometimes catastrophic nature of using living human donor cells.
The biology is messy.
Very messy. The bacterial endotoxins, the corrupted microRNAs, the fiery stress signals, it all stems from the highly variable reality of human biology. But what happens when we remove the human element altogether?
That's the million-dollar question.
Researchers are currently working toward a future where we don't harvest exosomes from human cells at all. Imagine a lab where scientists synthesize perfectly sterile, completely artificial exosomes entirely from scratch.
Building them from the ground up.
Yeah, they construct the lipid bubble and deliberately load it with a precise, mathematically calculated healing message. Zero risk of biological stowaway.
No damps, no hitchhikers.
Exactly. Zero risk of donor disease, zero risk of bacterial contamination. A true, pristine software update for the human body.
That would change everything.
It really would. But until that day arrives, stay curious, protect your biological hardware, and always question the source.